We're going to invite all of the faculty from the morning sessions to come up and join us for a Q&A panel. This first question is for Dr. Nissen. The patient writes, I have primary in the ileum with metastatic liver mets, and my question is, what's your recommendation for approaches to having the gallium scan to determine systemic disease before I start treating some of my known metastases? That's for you, Dr. Nissen. Yeah.
I'm being asked about a gallium scan. I think that if you have a primary in the terminal ileum with liver metastases, as both Dr. Singh and I said, there is value to considering a plan for removing the primary and addressing the metastases. The question of how the gallium-68 affects that, I think, was addressed a little bit in an earlier session. I'm not sure that it does affect it that much. We already know there's metastatic disease. The concept of debulking was brought up for liver tumors, which has symptomatic benefit and survival benefit. And getting rid of the primary tumor is very important. The primary tumor puts you at risk for obstruction, for what's called ischemia, which is bowel death. Ischemia is usually an acute event. It's not something that you're on the beach and you wonder, do I have ischemia? You know if you have ischemia, you're in the emergency room. So terminal ileum carcinoids are relatively easy to remove. They should be removed as part of the treatment plan. I don't think the gallium-68 factors in a lot, but it's very important, again, in the multidisciplinary strategy to figure out, how am I going to get rid of the primary? Do I do liver treatments at the same time, as a staged treatment, as a separate liver-directed therapy, and all that is key to that treatment plan.
Thank you. We have another question. Perhaps Dr. Singh could answer this. Would SIRS, the SIRS spheres, and portal vein embolization exclude patients for future PRRT?
No, I don't think so. At this point, I don't think it should exclude any of the patients for PRRT. There are a lot of patients actually who've received SIRS spheres, which is yttrium 90 beads for radioembolization, that have gone on and further got lutetium-177. My only point I'm saying is I am beginning to see those patients now 10 years later. And all I'm saying is don't rush and stack up all the treatments within a 2-year span or a 5-year span, because we don't know at this point what the long-term damage from all of this is going to be. I love the radiologists because they think the damage is going to be very little, but when I see these patients in the clinic, I see that, when they're cirrhotic at 10 years, whereas they shouldn't be, I know that something's going on that we still don't know enough about. So my point is just a little bit of caution, and I think space it out. Don't rush into the next round of treatment and the next round of treatment, which is kind of happening right now. So because these modalities are available, I would say stretch them out, and again, do it with your team, your surgeon, your medical oncologist, and your nuclear medicine person if they're involved with the therapy side of it.
Thank you. I'm going to direct this one to Dr. Hendefar. Patient writes, I completed the 13-month CAP-10 trial. I'm now off-label with CAP-10. What's the longest you've kept a patient on CAP-10 before risks outweighed benefits? This is from a pancreatic NET.
Can I pass? It's a very difficult but a very good question. The temozolomide part of the CAP-10 does have toxicity to the bone marrow that can be cumulative. It's part of a class of chemotherapy agents called alkylator therapy. Now, on the clinical trials that we did through the cooperative groups, we stopped CAP-10 after 1 year. There's a reason why it stops, because it is felt that the cumulative risk of Temodar starts to become an issue. So one should be careful. I think the capecitabine part is totally reasonable to continue indefinitely. There's lots of patients who've been on that medication for many, many years with no ill effects. But the Temodar you have to be a little bit careful about. So you should speak to your physician about whether or not it makes sense for you to continue the Temodar.
Thank you. This might be a question for Ken Herman. Where is Ken? Dr. Herman, the patient writes, it's been 68 days since my second PRRT. I'm having severe hematologic toxicity developed. Thoughts on time frame for bone marrow recovery? And second follow-up part to that is, if the scans indicate disease improvement, is this patient a candidate for a third PRRT based on the outcome of the second?
So the first question is, indeed, we do see hematotoxic or hematologic toxicity in patients who have been severely pretreated, which is actually not so unfrequently in the US, because patients only now at a very late stage get access to PRT. The situation in Europe is a little bit different, because patients would never get a Y90 treatment before PRT if PRT is available. So that's why it's really, what we see right now is not exactly where we have a lot of experience in Europe, again, because we have PRT available there. In this specific question, we usually know that after 6 weeks, there is the lowest nadir of all the bone marrow functions after the PRT-associated side effects. In this particular case, I would really, especially if the patient responded nicely, I would consider, depending on which protocol it is, if you can wait until the bone marrow proliferation has recovered. But this also depends again from the protocol. For example, if it's an expanded access protocol patients, you need to check that the patient stays within the protocol frame. And the second question I didn't really catch, to be honest.
It was about having a third treatment if the second one did recover.
Absolutely. It's very good to go. We have patients, again, the NET trial was really kind of arbitrary, that they went for 4 cycles only in the beginning. We, for a long time, performed routine-based 6 cycles. I have patients who have received 12, 14, 16 cycles. Of course, not within 1 or 2 years, over a long time span. But if the kidney function is fine, I do not see any reason to limit this.
Thank you. There's a question, how does a patient enroll in the NET-1 study? The NET-1 study has been completed, and those results are, have been published, and we're waiting now on it being approved.
There's an expanded access protocol, open access.
Yeah, open access. The expanded access program is what's currently available, several slots in select locations. And I think each of the institutions here, from City of Hope, Cedars-Sinai, and UCLA, can answer your individual questions about how do they find out about the expanded access program at each of our local Los Angeles hospitals. For the surgery question, are there liver debulking treatments that exclude surgery? For example, not regular or full anesthesia?
I think anesthesia is mandatory if you're working on the liver. I wouldn't do it without that. The only time you can have liver work done without perhaps formal anesthesia would be if you're doing a CT-guided ablation of a single lesion or a small lesion. You can do it under sedation and a little bit of local anesthetic. But even for that, by and large, most patients are better off with a short anesthesia.
Here's a question about scanning that could be for either med-onc or nuclear med. How often do you recommend scans to gauge progression or thereof, or how often do doctors need to review the actual scan results of progression?
I'll tell you what I do in my clinical practice. I tend to follow them like any other cancer patient. So I see all my patients every 3 months for the first 2 years, then every 6 months for the next 3 years, for a total of 5 years. The medical oncologists follow them a lot closer than I do. I get labs on every visit and 2 scans in the first year and the second year. if the tumor markers are elevated at any point earlier, they get an earlier scan. So in other words, at 3 months, they don't necessarily get a scan, they get just tumor markers in labs. And if those are elevated, I'll order the scan earlier. Otherwise, they go to 6 months, they'll get tumor markers, labs, and a scan, and that scan will be done in the first 2 years. I think it's necessary because you get an idea of the rate of growth of that particular neuroendocrine tumor, and you'll be surprised that there are people sitting here that I have treated 10 years ago who had a little ditzel in the liver, which is still a little ditzel in the liver. So again, I think we need to balance what we're doing, and so those patients are now once a year. I see them once a year and one scan a year and go from there. Nick?
Yeah, we follow them similarly, but what we've also tried to, parking around Cedars is difficult. And we've tried to make it a little easier on patients because our team has multiple components. We have oncology, surgery, radiation, intervention radiology. And so we follow the same schedule for imaging, but we may not directly see you that often. Often one team member will have a visit with you. The film review will be remote. We do a lot of phone interviews and phone consults. We all follow the scans closely, and you can tell an awful lot, with a 2-minute review of scans and a phone call. And for me, that's often how I'll do the in-between exams. I may see you once a year as well, like Dr. Singh later on. Early on, the intense film review is regular, but the visits don't have to be quite that frequent, especially when there's remote care, as a lot of us deliver. A lot of people travel quite a distance, and we're trying to, this is a marathon. We heard that expression earlier. You don't want to be making 18 visits a year for film review, which you can partly read in the report and partly get over the phone. So we do a lot of phone consults. We do a lot of multidisciplinary review. Every center has a multidisciplinary team that meets regularly and does these film reviews, and it's very, very key to the progress we've made in this disease over the last decade, is the formation of these multidisciplinary teams where we discuss symptoms, medications, film review. The last scientific meeting is brought up at these conferences. And again, that's where a lot of our film review happens, is Monday morning at our weekly meeting.
Yeah, I just wanted to add to those comments is that most guideline-based surveillance programs do encourage and recommend anywhere between 3 to 6 months for following up of low-grade neuroendocrine tumors. So it's totally appropriate if your physician tells you to get 6-month evaluation. That's commonly practiced and pretty much pretty standard.
Just real quickly to build on what Dr. Henifar said, but I also think that every patient's different, okay? And as Giovanna asked you guys to raise your hand today, you can see that there's a wide variety of patients. I have my patients here who have GI carcinoid tumors. I have patients who have pancreas neuroendocrine tumors. I have patients with lung carcinoid tumors and atypical lung carcinoid tumors. And those diseases are vastly different in terms of how they progress, how aggressive they are. And as a result of that, it's really an individualized basis decision in terms of how frequently you scan once you get a sense of the disease trajectory for that patient.
Yeah, I think that's actually really important because it was unclear to me whether the question was after potentially curative resection or in people with metastatic disease. And both of those actually do change with time. And just to amplify again is that when you're seeing patients over a long period of time, and I think the right word was trajectory, because of those people who, as Dr. Singh said, have very, very indolent disease, meaning very sleepy, very slow. That's the one that you want. And those people, you get bored having the same scan over and over again in a nice way. Other people, or if things may do well for a while, but if things start changing. I actually disagree a little bit with Dr. Nissen. And maybe I'm old school, but I always go over my scans, and if at all possible, in person. Actually, I think we may even have more expensive parking than Cedars, but it's
Yes.
in Santa Monica. But that being said, I do feel that at least one person, and often once you get farther away, even from the other, from surgery or other thing, even though you work with and we present the patients at our multidisciplinary boards, I personally feel that if at all possible, that this is a face-to-face meeting, and partly because, as actually I think Dr. Wong was saying, that what's on the scan report, is maybe very different than what the physicians are thinking. And my patients sometimes are really afraid of things that are normal findings, and they actually ignore things because they've seen the UCLA portal. There are things that I find really, really worrisome or important that it just goes right over their heads. And so even though you can do that by phone, I do think that, even though and we also have patients come from very far away, I think if at all possible to try to sit and look at the person and go over the scans in person.
Thank you. And I would agree that being bored is just fine. Stable results are just fine. There are a few questions here regarding biomarkers, which we haven't really touched on yet this morning. So maybe Dr. Hecht, you could start on this one, just about pancreastatin following chromogranin. At one point, if you see the markers start changing, do you want to test something else?
Maybe I'm old school. I still tend to use chromogranin A. The markers are useful, and markers are, and I'm curious what the other people think about that, but markers, they can also drive you crazy. And because the problem is that as an oncologist at the end of the day, and I think what you're talking about is in people with metastatic disease. There are actually two groups of patients you could talk about: people who've been resected, and then you're following markers, and then people with metastatic disease where there's metastatic disease. And as Dr. Nissen was saying, that you're also following markers as well. People's markers can change, and in someone whose markers go up, down, or sideways, with metastatic disease, as long as their CT scans are okay, then I'm actually pretty comfortable with that. Even though it may make me do scans more frequently, because as an oncologist, what hurts my patients in general, particularly I'm talking about non-functional tumors, is the tumor gets in the way and causes some problem. It causes liver failure, it causes an obstruction, it causes something else. In the patient who has been resected and has no evidence of disease, and the surgeon delivers the patient to the medical oncologist, even though we still work together, and there's no evidence of disease on any of the scans. I think it was Dr. Singh, perhaps, who pointed out that our scans are imperfect, and even when he goes in and operates, he can see disease that can't be seen by the radiologist, but even he can't see, even smaller disease sometimes. So where it's probably most useful then in someone, and why we follow the markers, is to get that more close follow-up in order to get more frequent scans. And so that's really sort of how I use it. I find it actually more useful in that situation than in the metastatic setting.
I would like to make one comment, actually. I think it's a little bit old school on this. So when I see a patient for the first time, I usually throw the kitchen sink at them. In other words, get most of the markers that are relevant to the disease process, i.e. if it's a midgut tumor, I will order a 5-HIA in addition to the chromogranin. So chromogranin, all neuroendocrine tumor patients get. Now there's, chromogranin B and C that are coming up, but right now the main emphasis is still on A. If it's pancreas, I get pancreatic polypeptide, pancreastatins, whatever you want to get. So again, relevant tumor markers. The reason I do it the first time is if any of those are elevated, they can be your best prognostic marker. So in other words, if you have somebody at 200 and you're following them after therapy and it comes down to normal, you know that you're going in the right direction. In the same token, if the chromogranin, the normal cutoff, again, there are two different levels in different institutions and different labs, but I'll tell you what ours is. Our normal cutoff is 95 at this institution. If it goes up to 110 or 120, please do not get perturbed by that rise in chromogranin, because that is probably within the realm of error. It'll probably come down. The most important thing to see in a tumor marker or biomarkers is a trend. And I always say, if the trend or the jump is not more than 200 or 300, don't let it bother you. because next time you come back, for all you know, it's going to be down to normal. So again, small rises, small fluctuations mean nothing. It's a 3-month and a 6-month continuous rise that means more to me than just a small jump.
Yeah, just to build on top of that as well, you know, I think for the patients I see, I always tell them at the first visit that, you know, markers are certainly a component of this, but it is not all of it. That we always look at 3 components when we're trying to assess for progression. First, how you're feeling. That for most is one of the biggest things. You know, for this disease, especially, you know, we're trying to make this a marathon, right? It's not a sprint, and you have time, and timing is everything for this disease, in my opinion. You don't want to start treatments too early, you don't want to start treatment too late, and it's really finding that sweet spot of time that's very important. So it's always how the patient is feeling, what the marker trend that has been mentioned is, and then ultimately the scan. And you take an overview of all 3 of these components, and all 3 of these components impact equally in terms of the overall decision of to whether initiate treatment or switch treatment or other things to make that decision.
I'm just going to say one quick thing. All that, I agree with everything that's been said, except if you have a functional syndrome. So I know that's what I'm talking about today. That's my job today. So if you have a functional syndrome, the tumor marker is essential to your management. So if you have carcinoid syndrome, if you have an insulinoma, if you have any, you know, VIPoma, if you have a functional disease, especially gastronoma, you need to check your tumor markers regularly.
Thank you. We have a series of questions all related to nuclear medicine. So I'll try to group these together. One question is, does PRRT work on bone mets? Is it effective on bone mets?
If there's somatostatin 2 positive, yes.
And one person asks, I know I have metastatic disease. I have not had a gallium scan yet. I'm nervous about finding out what else is there. I was told by one doctor not to have the scan because I might find out that there's more disease. So I noticed the numbers keep going up in terms of change management, and in what you presented from your study, UCLA, that more and more the treatment is actually changing as a result of the scan. So
yeah, I mean, the psychological response to not wanting to, or desire not to know and kind of hide in this not knowing is understandable. But if you want to be able to treat the disease adequately, you want to know what the extent of the disease is. So it's really important information to have, even if the results are disappointing or scary at some point.
okay, we have some disagreement. Pass the mic quickly.
Yeah, I mean, I agree that, you know, somatostatin scintigraphy is very important for this disease, and there's certain times where you need it, where it changes disease management. But when you have a metastatic tumor that's stable on somatostatin analog, for example, for several months, I'm not sure if additional testing would be necessarily needed. So I think for any test, it's just for medicine in general, a test, you need a question. If you don't have a question, you don't need a test.
Yeah, I mean, I was talking, you know, when you get initially diagnosed, so I agree with you.
But I think the questions and also the answers show that because the gallium scan is pretty new to the US, it's right now really the moment to find out when it's the right moment to use it. And actually, the Society of Nuclear Medicine is trying to do this, involving a lot of clinicians, defining the appropriate use criteria. And that's why I was surprised when Dr. Nissen said that he operates the patient anyway, because this is one of the questions where, at least in this appropriate use criteria, we all kind of agreed that prior to a surgery, it would be quite relevant to know the extent of disease, if there's metastasis, if there are, and I wonder if you would, for example, maybe change the approach to perform surgery in a patient if you know that maybe he doesn't have 1 lymph node, but maybe 7 lymph nodes.
So for someone newly diagnosed, would you, and I also want to point out that our gallium-68 scan is, the brand name now is NET Spot, so if you see that, you understand it's the same thing. For someone newly diagnosed, would you recommend that they have this as just in the same way they might have an MRI or a CT to determine the extent of disease?
If the patient has extensive metastatic disease, no. And this is pretty much also what Andrew said. If it's not going to impact the management of the patient, I would not do it. If a patient, for example, has really only localized disease, and I want to know that this is really localized disease, I personally would recommend it.
Yeah, I mean, I think for initial staging, there's no question this is the best test going. I mean, there's no question about it. I think sometimes what happens is a lot of the patients are seeing their oncologist in routine follow-up, and there's a certain treatment plan in place, and that additional imaging, like for example, if you knew that instead of 8 liver lesions, you had 12 liver lesions, that wouldn't necessarily change the management. So that's when it's a question of whether or not you really need a gallium scan. And then the other question that's for the oncologists are, so now that we have this gallium scan with this new information moving forward, how are we going to implement this? Are we going to be able to get gallium scans every year? So, are we going to go back to your default imaging to figure out how the patient's doing? So it adds some complexity.
Yeah, I think that, we were talking about that this morning in the morning session, is that, there are questions come up with payers. It comes up with even a small additional radiation. It's still harder. The other thing, of course, is with the assumption that, as Ken said, that the PRRT will be approved. Even if you're not ready for PRRT, one potential, at that time, someone has relatively stable disease, I could see where there may be some benefit in knowing that that would be a potential option in the future. I'm not saying that you need to do it right away, but I think a lot of patients, at least now, there's this sort of pent-up demand both for the gallium scan as well as PRRT in the United States. People wanting to know, at least, is that going to be something possible in the future?
And that brings up an interesting point about that not all people have the receptors. So we'd want to test for the receptors, and one question it specifically asks, what if I'm negative for the receptors, then what?
Then it does not make sense to make a NET spot scan or perform PRT. These are really the patients where we do not provide any additional information. Most likely, and this was Dr. Auerbach showed, is these patients who do not express somatostatin 2 receptors tend to have high proliferating tumors, and in this case, if someone would want to know metabolic information, FDG could be the right compound.
And I think that's just as useful. If you know a gallium is negative, that helps your plan your treatment going forward. So that's okay. I don't think that's necessarily bad. That's one of the benefits of the test, is that it tells you whether or not you have the receptor expression.
From a surgeon's perspective, gallium scan is not useful for anatomical planning. So from a surgical, if we want to plan an extensive surgery for the liver or the pancreas, we definitely want a good quality CT or an MRI over and above a gallium scan that actually probably gives you a better idea of the nodal disease. But I think we need, for the anatomy of the arteries and the veins, to know whether this can be resected, not resected, et cetera, or do we need to reconstruct it. The images that Dr. Nissen showed you of the head of the pancreas coming out, those sort of things, you will not get that clarity of information on a gallium scan. Gallium scan is either positive or negative in our mind. For anatomical planning, you need a good CT or an MRI.
And I have a question that maybe could go to Dr. Dahl. There's been talk about these tumors sometimes becoming more aggressive. So have you worked on some cases where you would re-biopsy, or maybe would the gallium scan be another option for or an FDG PET determine the aggressiveness of the tumor?
So yeah, there are rare gastroenteropancreatic neuroendocrine tumors which can undergo high-grade transformation. I have seen really few cases. So yes, if on imaging it's concerning, it's a good idea to biopsy that lesion because it may undergo high-grade transformation. This is not yet reported for lung NETs, but it's more common in pancreatic NETs. But you can see that in small bowel NETs.
And for Dr. Auerbach, it has been 13 years since my initial diagnosis, 5 surgeries, radioactive beads to the liver. I've had so many CTs. How many is too many CTs? Just a number.
Yeah.
No, I'm kidding.
7. No, there is no limit, because you don't image lightly. You image when you have a clinical question, when you know it's going to impact on the management of the patient. So the correct number, or the limit of numbers, the correct number of scans is the number of scans you need to appropriately take care of the disease without any limit.
And maybe for Dr. Hendefar, if the primary tumor has shrank due to Afinitor, is it a good chance that the other tumors have as well?
I hope so. That's great. Yeah. I mean, usually with cross-sectional imaging, you'd be able to see it. Usually the tumors do behave similarly. In neuroendocrine tumors, I would say as a general principle, you can have mixed responses, but I would say to something like Afinitor, that's not common. Interestingly, and it's something that hasn't come up today, but genomically or biologically, neuroendocrine tumors are not very complex. They don't have lots of DNA mutations or alterations, and they tend to behave as such. So I would say that if you have one tumor responding to a certain treatment, it's pretty common that they all are going to behave the same way.
And that's an excellent segue to our afternoon agenda, where we will be having presenters talk about inherited NETs. And for those of you who have submitted questions on that, we're going to save them for the afternoon. We also have 3 case studies this afternoon, so we'll address some of these questions more specifically then. And so before we break for lunch, I have one last question. What age is the youngest NET patient? Does anyone?
I've had 18 years old,
Yeah.
and there's actually a 19-year-old here who's not 19 anymore, almost 30. But yeah, 18 and 19 were the youngest I've done.
16. No.
16.
And that was an insulinoma. So, and I've shown this case at conferences, a 16-year-old who was behaving erratically, had an insulin-producing tumor that was affecting his judgment and other things. And so that was a remarkable case. This is a long time ago in our program. But if you have teenagers, and I'm soon to have teenagers, I'm always going to be thinking maybe they've got an insulinoma when they're doing reckless things.
Actually, we studied some patients with IBD, inflammatory bowel disease. We have an IBD center at Cedars, and I've seen young people with neuroendocrine tumors, IBD patients having neuroendocrine tumors. I don't know the exact age, but they were relatively young. And I think maybe it's because of increased surveillance biopsies, so we tend to pick them earlier. They were all incidentally found. Some of them were found during resection specimens. The good thing is they were very small lesions, no metastatic disease.
Well, thank you to all of the panelists and the doctors who presented this morning. Before we break for lunch, I'd like to do a quick informal survey. We always do this every year, but how many people were diagnosed just in the last year, last 12 months? Wow. I'm always amazed at how many new people. Well, welcome, and the rest of the people in this room are your new best friends, and we're here to help you and be resources for you, as well as all of these incredible NET specialists. So how many people were diagnosed in the last 3 years? And how many people have 5 years or more? Guess we count. How many people have 10 years or more? Yes. Keep your hand up if it's 15. Anyone at 15? Wow. Thank you. And why not go for 20? Any 20? 20. Okay. That's a good time to thank our AV team as well, Rich and Deb, for everything they do for us.